as well. So welcome to everyone for joining our Q&A session today. I'm going to say this morning because it's an early one for us here in the UK. It's 5 a.m. here, but for Dr. Weltman joining us from Sydney today, I think it's 4 p.m. in the afternoon for you just now, isn't it?
Yep.
Yeah.
True.
So thank you so much for joining us. We really appreciate it. And we were just saying there, we've got a lot of questions in. Our Q&As do continue to be as popular as ever, and we do get lots of questions in each week, which is great. So, but just remember, before we get started, these Q&As don't take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. And remember, if you need a bit more detailed information, if you have an issue, please give us a contact on the helpline. Also, just be mindful that Facebook is a public forum, and if you put any comments in there, and this is the last session, we will be streaming live on Facebook at the same time as we're hosting it here in Click Meeting. We're moving more into the safe space here within Click Meeting, but we'll also be recording the session here and uploading it to our YouTube channel as well. Just remember, if you are joining us in the room here in Click Meeting, the chat and the questions that you'll see, the typed information you'll see on the right-hand side is protected for a safe space, so that's not recorded. It's just the video of Dr. Weltman and I that's recorded. Okay, let's get started with the first questions we've got sent in. So our first question today is from someone who lives in Northern Ireland. They're the only person at their local practice with PBC, but they're lucky enough to be able to get their bloods checked by their doctor there every 3 months. So when they make the appointment to ask for the liver function test to be done, they just want to make sure they're asking for the right thing. So what should they be asking for?
So that's good. You're probably not unique. There's probably a lot of people with PBC who are the only one in the practice. I think that at least twice a year it would be worth having your lipids measured. In other words, your cholesterol and your lipid profile. And it would be reasonable at least once a year, if not twice a year, to get your vitamin D checked as well. At the bare minimum, if you get those done, you don't have to do them every 3 months. And in fact, if you're doing well, you don't even have to get your liver test checked every 3 months. You could do them every 6 months if everything's good.
Great, thank you. We have someone asking about, we have had quite a few questions recently about weight loss injections, and we've done a little special on that that's up on our YouTube about the injections themselves. But someone has contacted us to say that they've read an article in the News Health section regarding weight loss injections, and the article stated they're being researched to help combat liver disease, and just asking if we know about anything about that.
So weight loss drugs fit into the class of drugs, the modern weight loss drugs, or GLP-1 agonists. There are lots of studies looking at different GLP-1 agonists and the impact on mainly non-alcohol related fatty liver disease. So there have been trials, we've been involved in trials with what's called semaglutide, which is now coming to close to the end of a phase 3 studies looking at it specifically for non-alcoholic or metabolic associated fatty liver disease. It's probably not going to have a home for other liver diseases. It may, there are some studies looking at it in people who have alcohol related liver damage. So there's some early studies that are very almost like a little niche study exploring that option, but it's not going to be used for all liver diseases. And it's people who have fatty liver disease are usually overweight and often have risk factors for type 2 diabetes, and so that's what these drugs are targeting. But they probably do benefit the liver disease in those individuals.
Great, thank you. Patients saying they've been diagnosed a year now and they haven't had a FibroScan yet. Is that a normal time frame, and how often should they have their FibroScan repeated once they get it?
Okay, so I don't know what, it depends where you are and what access you have. Our patients do wait about 6 months just because that's the wait time at our particular hospital. So usually that's not an urgent thing. If they were more worried about your liver, they're worried you may have cirrhosis or more advanced liver disease, that may be a concern. We don't repeat them that frequently if people have very low levels of fibrosis or no fibrosis based on the FibroScan. So if they get a very low FibroScan reading, we may not repeat it for several years. If it's a lot higher, then we'd want to track the fibrosis and make sure that it's not getting worse, occasionally even improving. So we would, in those individuals, we might do it annually or every 18 months, something like that, depending on what wait times are at the particular centre.
Great, thank you. A patient asking about their current medication. They've seen a new consultant. They're currently taking, I don't know if I'm pronouncing this right.
Budesonide, yes.
Budesonide and 1,500 milligrams of urso, and they want to change it over to a medication that's used for Crohn's disease, azathioprine, but and that they would be closely monitored, and they may have to have another liver bypass. That was a term that I wasn't familiar with, actually. Is that a TIPS procedure?
No, I think they must be referring to a biopsy, not bypass.
A biopsy, right. I also had a FibroScan and the stiffness was in normal range. Is that normal for?
So none of that sounds very unusual. To be honest, that's not PBC. So budesonide's never used in PBC. Azathioprine, which is used in not just Crohn's disease, it's used in lots of diseases and immunosuppressive agent. It sounds like they think this individual may have autoimmune hepatitis and a PBC overlap, because that's when you'd use azathioprine and you might use budesonide. Budesonide is not commonly used in autoimmune hepatitis overlap syndromes, but it could be used in that circumstance. That's quite a high dose of urso as well. So there must be some reason that the doctors are very concerned, and this is not, the budesonide and the azathioprine are not for PBC. So I think you need to have that discussion with the doctor and understand what their concerns are. And I'd imagine they're concerned about autoimmune hepatitis and an overlap syndrome where you get a bit of both diseases. The fact that your FibroScan stiffness scores are normal is reassuring, and they've got time on their hands to make these decisions with regards to the medications and what suits you best. But you need to ask why you need those medications of your doctors. That's an unusual step if it's pure PBC.
Great, thank you. I'll make sure that patient gets information on that. Our next one is patient with advanced cirrhosis caused by PBC and asking, should they still be taking urso at this point, and does it still help at this stage?
It's the chance of us helping is very small, but if it helps, and it may, because we do have patients where it unexpectedly benefits those individuals, a very safe, simple drug, and it avoids those more complex drugs. Some of the newer drugs you can't have if you've got cirrhosis. So they would use urso, and they may want to add another drug in. That one of the newer agents, second-line agents that are coming through. They might want to add that to urso because it's a good combination. So there's not much downside to having the urso. But you're right, it may not be hugely beneficial, but it may be beneficial if they add a second agent. So you may get a cumulative benefit, and I would encourage you to have that discussion with the doctor treating you.
Great, thank you. Patient who was diagnosed late 2023 with raised liver biochemistry and low alpha-1. They've responded to urso immediately, and their LFTs are now really back within normal. But their FibroScan has jumped from F1 to F3 in 12 months. Just asking, does that make sense? A previous special ultrascan, when diagnosed, showed severe scarring also. Just wondering why the scan results are so inconsistent.
Yeah, that is a concern, that it's so inconsistent. Your liver tests are not typical of PBC, actually, your initial liver test, because you haven't reported on your ALP, and that's what we typically look at in PBC. But the point is that you've responded well. but there's been an unexpected increase in your liver scarring or liver fibrosis. In that scenario, that would be a real, if that's real, that's a concern, because some people, in spite of a biochemical response, get progressive liver disease.
Mm-hmm.
And progressive liver disease means they get further damage to their liver, like scarring. If we see patients like this, we'd repeat the FibroScan again just to be sure that it is a real finding. If it's real finding and it's not what we would expect, and it's counterintuitive in terms of your other findings, we would get a liver biopsy done in that scenario to clarify the situation. Because if you are getting progressive liver damage in spite of URSO, one needs to consider other approaches to the management of this disease, and that's a discussion you should be having with your consultant.
Great, thank you. Patient who's been diagnosed a year ago with PBC and they're taking URSO. They've gained weight. Their liver specialist tells them it's not to do with the URSO, but they have seen on our website that weight gain can potentially be a side effect of URSO. They are trying really hard to keep eating healthily and exercising, but they're just wanting some clarity around, can you gain weight when you start URSO, and what should you expect moving forward?
You don't really gain much weight with URSO, really, to be quite clear. And I'm not sure how old you are. So there may be other metabolic factors that are, most of our patients we get is here a woman in their 50s, and there are other metabolic factors that happen around that time of life. So that should be looked at. You should make sure you don't have risk profile factor for diabetes and metabolic syndrome. You're doing the right things with your exercise and healthy eating, but we would encourage our patients at that time, if they're still putting on weight and apparently doing all the right things, we would get them to at least see a dietitian to clarify that the diet is the best diet they should be having.
Mm-hmm.
But I doubt this is related to the medications. So you may need some further assistance and guidance around weight loss itself.
Great, thank you. Our next question is from a patient who's asking about Botox and fillers. Now, there might be some people watching who think this question's from me, and I may be interested in the result, but is Botox and fillers okay for someone who has PBC? The patient's read it can go through the liver, so should be avoided.
I don't think you should be too concerned. The risk would be low.
Thank you. Yeah. Asking about their general care. So is it important to be under a specialist consultant versus a hepatology consultant in the gastro department who covers all liver issues in general? Where's the best for, I know not everyone has access to a specialist centre. So just thinking about if people do, what's the best
I think, I'm not sure because of that terminology. We use slightly different terminology in Australia. So people would be either under a general gastroenterologist or a liver specialist.
Right.
And I don't think it matters. I think the preference would be to have someone who has expertise in liver disease, but some of the general gastroenterologists may have a degree of interest in PBC, and they would manage this quite well. And that's the question or the inquiry you should pursue.
Yeah.
But most people would be better off at least some of the time seeing a liver specialist. And if it's straightforward PBC, a general gastroenterology consultant would be quite appropriate.
We touched on fatty liver earlier, but we've got someone asking, is it common for someone with PBC to also have fatty liver?
So PBC is not common, as you all know. Fatty liver today is very, very common because there's more weight gain in society. There's more type 2 diabetes in society. And there are more people who have underlying metabolic risk factors for the metabolic syndrome, and that's what predisposes people to fatty liver, as does alcohol. I'm assuming alcohol is not part of the spectrum, but people who drink heavily get fatty liver as well. fatty liver goes with everything. So unfortunately, because it's common, PBC is not, but you're going to have a lot of people who are in that age where they gain weight. And the one thing when my patients see me in the clinic, they say, what can I do for myself? Well, we really emphasize taking the best care they can around their weight and managing their weight, because fatty liver is not good for PBC and vice versa. PBC is really not good for fatty liver disease. So fatty liver disease in a lot of Western countries is now the most common cause of, or it depends on which country, the first or second most common cause of cirrhosis of the liver and of liver cancer. So it's not a benign condition for everyone, and people should make the effort to try and address that.
Great, thank you. Just following on from that, another patient has asked, can an MRI with contrast show fatty liver? That is, if the abdomen was being scanned with MRI for other reason, would it show that fatty liver was
probably
present?
would. Yeah, it probably would. I mean, if the radiologist is made aware that's your concern, yes, it would. I mean, we mostly use ultrasound for that purpose because ultrasound's done more frequently and easier to get access to, and that's a very good way of looking at fatty liver. But yeah, an MRI would certainly show it. The one issue around MRI is that there's so many different softwares that are set, so it depends what the MRI has been used for.
Mm-hmm.
So you can get MRIs of the bowel, and that probably wouldn't be as good as looking at that. Look at the liver, and that tell you there's no lumps or tumors, but that probably wouldn't be good at looking at fatty liver. On the other hand, you can get a thing called an MRI PDFF, and that will accurately measure how much fat there is really. It'll quantify it in great detail, how much fat there is in the liver.
Great, thank you. Patient asking, is there any reason why the mornings are worse for their fatigue? They do have fatigue the rest of the day, but find it particularly difficult in the morning.
Yeah, it's a well-recognized phenomenon that you've had a sleep and then you wake up with fatigue. It sounds so counterintuitive. It's a very, very, very it's a very sorry, they're trying to log me off clinic. Yeah. Then they sorry, my mind slipped. The morning fatigue is a well-recognized phenomenon. There's publications showing that, and no one really knows, because we don't fully understand why people get fatigue with PBC more than they do with other liver diseases, and it's probably a bit differently to other liver diseases too. But that early morning fatigue is quite a recognized phenomenon, and no one's worked that out.
So, patient with PBC, do they have a higher risk of cardiovascular disease?
No. I saw that question. They don't. They have a higher risk, a slightly higher risk of hyperlipidemia, so high cholesterol, high lipids predispose you to cardiovascular disease. But there've been a number of publications which haven't shown which have looked at this and haven't shown an increase in cardiovascular disease risk profile. So there's some that have hinted that it may be, but there's not been a study that's statistically shown an increased risk. So I'm not sure where that's coming from. I haven't come across this at all.
Okay, thank you. Can osteoarthritis cause an increase in ALP?
Definitely not, no. And osteoarthritis is common as people get older. Most people get a degree of osteoarthritis.
If you're deemed an URSO responder, does that mean your blood work returns to normal or close to normal, but may not always be perfect?
Yeah, that's a very smart question, and that's Mo's been in some of our discussions of the medicos at the PBC Foundation. That's something we have heated discussions about. So ideally, whatever treatment you're having, the target should be not to normalize your ALP. That's how that would be our goal, and that's what I tell patients. Not you can't always achieve that, so you want to get the lowest ALP you can get would be what you might have to settle for. Now, with all these newer medications coming through, if there's a suboptimal response, and the people the experts who control the regulatory authorities like the FDA and the EMA, and in Australia the TGA, which regulate medication, follow the original studies that say your ALP has to be 1.67 times the upper range of normal to get a new medication. So it's really hard if someone's say 1.2 times the upper limit of normal. I think it's archaic, and we should be doing away with that, but the regulatory authorities are not going to do away with that in a rush until someone's defined. They're very good studies that define the benefit of normal, even though experts in the field and the studies to date in the field suggest there is a difference. It can be quite marginal, but you can be slightly elevated and you can be normal, and there is a difference in outcomes with regard to liver damage. Now, sometimes it's so subtle it doesn't make any real difference for an individual, but our target nevertheless should be a normal ALP as best as we can get there.
And that's where the benefit of our new second line medications coming along as well,
Correct.
is that there's new options for that too. Can PBC cause trouble sleeping? And is there anything that can do to help with that?
I don't think it actually causes trouble sleeping. I think a lot of people have trouble sleeping, so people with PBC can just have the same difficulties sleeping as a whole lot of people who don't even have health issues otherwise. So a lot of a high percentage of the population have trouble sleeping. So it indirectly can cause trouble sleeping. So some people become very moody, and the moodiness may lead to even depression. So people with depression can have trouble sleeping more than people without depression, for example. That's very indirect. It's not the PBC itself. It's the PBC may have ultimately led to a bit of depression and moodiness, and that interferes with sleep. I don't think the PBC per se causes trouble sleep, interferes with sleeping.
Okay, thank you. Just to say as well, for patients, if they are struggling and maybe with a new diagnosis, or if they are struggling to sleep because they're worried about their PBC, please reach out to us for a chat on the helpline. And also we have our Choose Me Tuesday sessions every Tuesday with Cheryl for self-care. So things like that can be really important to help.
Yeah.
Can someone with PBC donate blood?
So it's going to be different in different jurisdictions, so different countries, and really we are in Australia. If you have a liver disease, it's very difficult to become a blood donor.
Right.
There's an argument if your liver tests are normal that you should be a blood donor, and they will sometimes consider that argument. So if you've treated PBC and your blood tests are normal, they would look at that. So I'm speaking from an Australian perspective. Some countries are more lenient and they would take patients with PBC, and other countries have very rigid rules around underlying illness as a blood donor. So it really, I'm going to answer the question from an Australian perspective, but it depends on the jurisdiction and the regulations in each jurisdiction.
Great, thank you. A patient asking about, is brain fog indicative of advanced PBC, or can it be prevalent at any stage?
That's really good, thank you. It can be prevalent at any stage. We see it more in advanced PBC, but it doesn't always correlate. The people who even you give them urso, for example, and their liver tests normalize, and they don't have bad liver disease, but they have very pronounced brain fog, fatigue, those sort of neuropsychiatric type symptoms, and you see some people have it really badly in spite of the fact their PBC is not very advanced. Now, in those situations, I always ask people to get back with their family doctor and general practitioner and make sure there's not another reason for brain fog. Some people can have coincidentally some other explanation for brain fog. There are lots of causes of brain fog, but it's true that it doesn't always parallel the severity of the disease.
Thank you. We've got a couple of questions around things being connected to PBC. So the first one is there any relationship between peripheral neuropathy and PBC?
Not really, no direct relationship.
Is there a link between PBC and breast cancer?
No, there's no link.
And when patients have PBC, should they be regularly tested for other autoimmune diseases as standard? We know that often if you have one autoimmune disease, you can have another. What are the ones that we would regularly see with PBC? You might want to just cover that. What patients?
Okay, I'll answer that question. You don't need to be regularly tested for autoimmune disease. Sorry, my computer's going to restart, so I'm just going to shut this. You'll hear me, but I have to tell it to snooze, and then I'll come back. Typical in a big organization, they want to shut down all the computers to do something. Anyway, you don't have to regularly be checked. They may do some simple related checks right at the beginning, and they would check you if you had symptoms. So the big ones that we should be aware of are autoimmune thyroid disease, Sjogren's syndrome is the big one, really, and they're probably the big two that should be looked at. And some doctors will only look at that if you've got symptoms. I don't think there are any specific guidelines of whether you should always check or whether you should check if someone has symptoms. We don't check all our patients, but if there's a hint of anything, we would run a broad autoimmune disease. Some people have a broader range of autoimmune diseases like SLE or lupus, scleroderma even, so they do celiac disease, so they sometimes get a broader range of these diseases. People even get autoimmune gastritis and pernicious anemia, so these things do happen, but Sjogren's and thyroid disease are probably the most common.
Great, thank you. Patient who's recently been diagnosed with PBC, not started on Urso yet, just getting that organised. Any tips for them? So just thinking about that as a general question, if we've got someone who's newly diagnosed, what do they need to be thinking about in terms of regular monitoring and anything else around that?
So it's, we try to individualize our approach to patients nowadays, certainly at a specialist like me who has a specific interest. So I would look at baseline risk factors. So if someone has risk factors for more aggressive disease, so male, younger woman, a lot of a high FibroScan reading or a lot of fibrosis on biopsy at the start of treatment, I'd want to jump on a treatment and probably keep a closer eye on that person, maybe initially every 3 months, because the treatments take a long time to see benefit from these treatments. And then if they're responding, just stretch it out to every 6 months. But some of my patients who have very mild disease and it's picked up incidentally, so there was a slightly high ALP, the general practitioner ran a bunch of liver test orders, as we call them here. So some software has that, and they come up AMA positive. If there's not much of concern, there'd be no rush to get under treatment, but we'd organize the treatment, we'd educate that patient, and then we'd see them in 6 months' time. So they're different spectrums of disease, and that depends where you sit. But most people don't need to be seen that frequently, really, to be quite honest, if they.
You touched on two things in your answer there that's actually, we've got two other separate questions on. So what are the extra risks or symptoms for young diagnosed patients, so 35 and under, that we'd need to take into account?
So there's no extra risks, but you have to have we'd hope that your consultant or specialist understands, and they don't all. I mean, I go around and I've give lectures on this to gastroenterologists, and some of them get a bit surprised, but younger people have a higher risk of having more aggressive disease. So you just need to have awareness if their URSA doesn't work effectively
Mm-hmm.
at a reasonable point, so up to 12 months. I even go to 6 months, I'll make a decision often and would transition them to a second line agent. So until recently, in Australia, we only have obeticholic acid. Some countries don't have it anymore. We have it, so that's what we use, and there'll be other drugs coming through, and we'd want to make sure that we don't slip up with that person, we don't miss that person. Now, if they've got a normal FibroScan, we're a little bit less concerned than if they had a high liver stiffness score on FibroScan, etc. Then if they're male, we'd be even more concerned because they do more poorly. If there's a woman who's going to plan on at that age on future pregnancies, would want to be very aware if they fall pregnant and would want to be engaged, because we've seen patients, the odd patient who flares around or after pregnancy.
Mm-hmm. You touched a bit there on PBC being more aggressive in men than women. Could you talk for us a wee bit on the differences between PBC in men and women?
I think, first of all, men hardly, we don't see that many men with PBC, if we really, and so they tend to be younger. They're not always, and they tend to certainly the literature supports, and the ones I've seen, they tend to have very aggressive disease. They get a lot of fibrosis quite quickly.
Mm-hmm.
And in fact, I've seen people where they've missed the boat. They're already cirrhotic, and no one's thought of PBC. So no one thinks of it really in men. It's quite interesting. But if they had a high ALP, they should have serology for for PBC, and that's the main thing with men is this. Is they tend to have very aggressive disease, and the progression to cirrhosis can often be much quicker. So we should, I don't know if there are any men on the listening to this, but your antennae if we get referred someone or pick up someone, a male, our antennae really shoot up, and we we make it very clear to them they can't slip up, they need to see us regularly.
Okay. We do have many men who join our support sessions as well, which is great. But I'd just like to say, if there are any men and they are concerned about their disease progression, then please give us a call on the helpline, and we'll do what we can to help.
I would encourage that too.
Yeah. Just when you touched on the new medications there, Dr. Weltman, are the 2 new medications available in Australia at the moment?
No.
Or are they still coming through?
They're going through the so they've been approved through the equivalent the Therapeutics Goods Authority, so they are licensed in Australia, but they're not commercially available on our health system yet. And they're both going through that process. I think the one is ahead of the other. One's they've had all the meetings and the presentations and the patient and medical input. So the other one's about to go through that whole process.
That's great. So that's elafibranor and seladelpar.
Seladelpar, yeah.
Yeah, that we're starting to
So
see come through.
they're going to be imminently available, I would think, but it's far, their regulatory authorities and their government organizations, I can't predict what they do.
No. Yeah, and it is taking different time spans within different countries as well for that to happen, but it's good to see that's starting to come through.
And we're fortunate in that some countries have lost obeticholic acid, and we haven't.
Yeah, so that's still available at the moment.
That's not gonna. It's going to remain available, I believe. Yeah.
Good. We touched on fatigue earlier, but we get asked this question quite a lot. Actually, we've got a patient asking if we're aware of any new research for fatigue and PBC.
There's not a lot. There's generally not a lot of sophisticated research on fatigue. There is research, obviously, but it's not the volume of research that you'd see with a whole other bunch of things. And it's hard because it's such a non-specific symptom, and it comes about with so many different conditions. And there are some early clinical trials. I'm not aware of any details. I think there's very small pilot studies looking at neuro agents that will work on the brain to try and help with fatigue. Whether they'll translate into anything, it's very early days, very, very early days. But in a sense, that's why people who move into this field are used. They don't work with PBC. They work with brain illness and fatigue, and psychiatrists and geriatricians and people who look after illnesses with fatigue. They have no idea about PBC. That it's an afterthought for them because it's not a common disease, and within that, only a proportion of people get fatigue. So it's not high on the agenda for pharma. But when every time a pharmaceutical company who's in the R&D space hears about this disease, they gravitate towards people who know about this disease to see if their drug or therapeutic agent would have some role. But there's nothing around the corner, I'm going to tell you that.
We have been working with one of our industry partners who are looking at fatigue and PBC, and they are doing early clinical trials in the UK and starting in Europe as well.
What I was talking about.
Yeah. So if anyone would like some information on that, I can share details of the clinics that are involved in that, certainly from a UK perspective at the moment, but they are starting to recruit in Europe as well. That's us come to the end of the questions that we've got sent in, and there's not any more questions that have came in live for us either. We've got a wee bit of time left, so I just thought we would maybe just touch on the International PBC Summit that we've got coming up. So this is the third year that the Foundation have organised an International PBC Summit, where we bring together we just bring together the PBC community in general. So that's all our clinicians, our industry partners that we work with, and all the other patient support organisations from across the world as well. We have truly international attendance again this year, and it has been more popular than ever, and we're really looking forward to seeing everyone in Edinburgh. Have you been at all three with us, Martin? I think this will be the third one, isn't it?
Yes.
Yeah.
It's hard to say no to Robert. I thought
it is very hard to say no to Robert.
And then I get these emails, you are coming, aren't you?
And we're looking forward to seeing you. So it is we've got new patient organisations from other countries joining us this year as well. We've got over 20 patient organisations that are joining us in the room internationally, which is amazing. Some of these organisations are just covered by volunteers, so there's not the full-time employees working as there is within the foundation. So us being able to share that, and when we get funding for the summit, we are able to sponsor the other patient organisations to come over and be part of the bigger conversation in PBC as well. So that's really important for them as well. I'm just double checking. We've got no more questions in. I think I might give you a wee bit of time back this morning, Martin. I know it's getting end of day for you, isn't it?
Yeah, there's still a clinic downstairs, so that's good. They need me there.
I'll allow you to go back to your patients then. Thank you so much for spending some time with us today. That's been lovely, and I look forward to seeing you soon.
Absolutely.
Take care. See you later. Bye.